just make a mention of the resources much of this lecture was based on come from three outstanding organizations. NIDA, which is a branch of the National Institute of Health, and its mission is to advance the science on drug use and addiction and apply that knowledge to improve individual and public health. SAMHSA, you might have heard of, is another government, US government organization that was established by Congress in 1992 to make substance use and mental disorder information, services, and research more accessible to the, to the public. The organization that I'm involved with is ASAM. ASAM is the American Society of Addiction Medicine, and it was founded in 1954, and it's a professional medical society representing over 7,000 board-certified physicians, clinicians, and associated professionals in the field of addiction medicine. ASAM is dedicated to increasing access to, and improving the quality of addiction treatment, educating physicians and the public, supporting research and prevention, and promoting the appropriate role of physicians in the care of patients with addiction. Currently, I'm the president of ASAM in the Midwest that covers 3 states, and we're moving forward with trying to disseminate this type of information like you're going to hear tonight, hopefully making a dent in this crisis. Next slide. Now, this is the crisis we're talking about. The United States right now is in the midst of an opioid crisis that first emerged in the 1990s and has reached epidemic proportions within the last decade. If you look at this graph, fueled by the advent of synthetic opioids, the number of annual overdose deaths has almost doubled between 2010 and 2019 here in the USA. While death totals remained relatively steady between 2017 and 18, actually you see a little dip in this graph where there was a reduction in opioid pill prescriptions. Provisional data from the CDC indicate that there were an estimated 100,000 drug overdoses in the United States during a 12-month period ending in April 2021. That is an increase of almost 30% from 78,000 during the same period the year before. Now that is alarming because there was a trend to stabilizing this graph, but something happened. Something happened in 2018, 2019. And what happened was the pandemic. The onset of the pandemic was associated with an increase of overdose deaths, as you see. The increase of opioid overdose deaths during the pandemic has been attributed to several factors, including reduced access to interventions. If you could imagine that historically addiction services was a very social kind of experience where you went to groups, you went to support groups, you did face-to-face. And when we were told that we couldn't do that, there was a crisis in our space specifically. There was also an increased level of stress due to isolation and the loss of mental health support services. And lastly, what we saw was the change in type of opioid. This is what we consider the 4th wave of the opioid crisis, starting with opioid pain pills, moving to heroin in the 90s, and then the fentanyl crisis recently. Now, the 4th wave is a mixture of fentanyl and psychostimulants, namely methamphetamine. And that has been the real reason why there has been an uptick in overdose deaths in the last several years. Next slide. The rise of fentanyl and its metabolites is driving the current increase of overdose deaths currently. As you see, fentanyl is just separating like crazy from the other lines. Fentanyl is approximately 50 to 100 times potent as heroin. Fentanyl and its analogs are being mixed into counterfeit opioid pills, heroin, cocaine, and methamphetamine. The illicitly manufactured fentanyl analogs, such as acetylfentanyl, furylfentanyl, and carfentanil, are likely the drivers of this trend. Next slide. Many people really don't understand why or how other people become addicted to drugs. Many mistakenly think that those who use drugs lack moral principles or the willpower, and they can stop at any time. But in reality, drug addiction is a very complex brain disease involving networks in the brain that talk and work together and make sense of life. Quitting usually takes more than good intentions or strong will. When exposed over time, drugs or alcohol in the brain changes the brain in ways that quitting is very, very hard, even those who really want to. Fortunately, researchers and addictionologists like myself know more than ever about how these drugs and alcohol and these substances of abuse affect the brain, and have found effective treatments that can help people recover from addiction and alcoholism and continue productive lives. Next slide. Now let's talk about the brain. This is how the brain works. Dependence affects, or addiction, when we talk about addiction, we talk about drug dependence. It affects both the cortex and the limbic system. The cortex, you see, is the big part of the brain. Now, this involves the decision-making, thinking, reasoning, and planning part of our brain. This is what I usually like to call the wizard brain. Now, on the other side, we have the limbic system. Excuse me. The limbic system is a deeper part of the brain that lies deeper inside the middle part of the brain, and usually is responsible for the basic drives and urges, rewards, and pleasure. This is what I usually like to call the lizard brain. Now, the lizard brain and the wizard brain actually work together to make sense of their environment. Now, if you can imagine the lizard brain being in control of your behavior, you can do a lot of things that are very impulsive and very reptilian, and sometimes can be very dangerous for you. That's why the wizard brain has to come in and kind of guide the lizard brain and say, hey, you know, you can't do this, you can't do that. But in addiction, the lizard brain is in control. And so one approach that is what we do in INSynergy is we address the dysfunction of the lizard brain by using medications that reduce the activity of the reward system. Now, when that happens, the wizard brain can have more opportunity to make decisions in life. So that's kind of the crux of addiction. You use both medications and talk therapy behavioral interventions. Next slide. Define addiction. What is an addiction? So addiction is a chronic disease characterized by drug seeking and use that's compulsive and difficult to control despite harmful consequences. The initial decision to take drugs is oftentimes voluntarily for most people, but repeated exposure and drug use can lead to those brain changes that challenge the addicted person's self-control and interfere with their ability to resist intense urges to take drugs or drink. These brain changes can be persistent, which is why drug addiction is considered a relapsing disease. And people in recovery from drug use disorders or alcoholism are at increased risk for returning to drug use even after years of not taking the drug or drink. Next slide. So here we have an example of what happens to the brain when exposed to, in this example, methamphetamine. So on the left, you have a healthy person's brain with the red describing a normal dopamine function in the brain. When you use meth for a while, for at least after a month of quitting, you can still have dysfunction in the brain and dopamine receptor dysfunction. The good news is after at least a year, and in this brain scan, 14 months of abstinence, the brain tends to go back to equilibrium and regain that function. So there is hope. Sometimes the brain's circuit is permanently changed, but in a lot of cases, you can go back to equilibrium after long periods of abstinence. Most drugs of use and misuse affect the brain's reward circuit, causing euphoria as well as flooding it with a chemical messenger called dopamine. So a properly functioning reward system motivates the person to repeat behaviors needed to thrive, such as eating, spending time with loved ones, sex, things that are necessary for survival. Surges of dopamine in the reward circuit causes reinforcement of pleasurable but unhealthy behaviors like taking drugs or drinking, can lead people to repeat these behaviors again and again. So this is why addiction is considered to be a relapsing disease. Over time, the brain adjusts to the access of this artificial dopamine release, which reduces the high that a person feels compared to the high that when they were first taking the drug. This is kind of a term we hear, it's called tolerance. So it takes more than was previously needed to get that same high. Next slide. No one factor can predict if a person will become addicted to drugs. So a combination of factors can influence addiction, such as genetics. That's why we see addiction or alcoholism traveling in families. It could be environmental. Obviously, the repetitive exposure of the drug or the alcohol. And most importantly, out of this list is what we call comorbid psychiatric conditions. If you can imagine, if somebody is depressed or has anxiety or sleep, they may find drinking or using drugs appealing to address those feelings. The more risk factors a person has, the greater the chance that drinking or taking drugs can lead to addiction, and vice versa. Treatment is focused on identifying all the risks and eliminating those individual risks can promote a better outcome. Next slide. Now, can addiction be cured? As with most other chronic diseases, such as diabetes, asthma, and heart disease, treatment for drug addiction, generally there isn't a cure. However, like those other diseases, it can be treated and successfully managed. The idea is intervention, regardless of if it's behavioral or medical, are those interventions preventing an early death? And for addiction, just like asthma and hypertension, the answer is yes. So here we compare the relapse rates for people treated with substance use disorders with those for people treated for high blood pressure and asthma. And relapse is common and similar across these illnesses. Therefore, substance use disorders should be treated like any other chronic illness. Next slide. Okay, so it is very important to screen. There was a question in the chat box earlier asking what blood markers are indicative to alcohol use disorder. Sometimes workups like that can lead you or signal a question to your patient. Hey, your liver enzymes are a little high. Do you drink alcohol? And tell me about it. But the trick is you have to ask. So SAMHSA recommends that using these tools in a normal, comprehensive kind of medical workup is necessary. So it is they recommend that screening every patient with a validated screening tool has been shown to be a superior intervention in identifying substance use disorders. Next slide. And some types of screening tools they recommend are the following. One's called the audit. That's something that we use in INSynergy. It's really easy to administer. We give it to the patient to fill out, and it can identify drinking patterns, and it can give you a score, and it kind of helps with determining whether or not there's a problem. So it's called the audit, the alcohol use disorder identification test. There's another one that everybody's familiar with, the CAGE questionnaire. I think when I was in medical school, that was the popular one. And the CAGE is short for 4 questions. Have you ever cut down? Are you annoyed by your people? Are you annoyed by people telling you that drink too much? Do you feel guilty of your regarding your drinking? And do you have eye openers? So if you have an eye opener, that really kind of tells us that it's a good screen for alcohol use disorder. But 2 out of the 4, you should be asking additional questions. And again, these screening tools can be part of a medical, I guess, workup. You know, you don't have to be always suspicious, but it should be something that you should be always asking, including, you know, do you smoke cigarettes, or what are your drinking patterns? Next slide. So the reason why we ask is because mood disorders are associated with substance use disorders, almost hand in hand. And this slide kind of looks at the alcohol use disorder and how many different mood disorders are common with people who are struggling with alcohol. And in one study, patients with alcohol use disorder was 3.3 times more likely to have other substance use disorders. So it's very, very important that you screen for anxiety, ADHD, major depression, bipolar, personality disorders, and anxiety disorders like PTSD and panic disorder. Next slide. Now, this slide illustrates that many of these mood disorders are highly associated with drug dependency or alcoholism. And something that's surprising to many people who are in the treatment of addiction is how high ADHD falls in this list. You would expect things like bipolar disorder, anxiety disorders, and just regular depression to be high on this list. But what is very, very high is ADHD. It's the impulsive nature of people who have this condition that sometimes gets them, you know, in trouble with substances. If you think of what ADHD is in the brain, what kind of condition it is, it kind of makes sense, because you treat ADHD with medicines that increase dopamine. And if non-ADHD brains would use a medicine that increased dopamine, such as Ritalin or Adderall, we'd be a little hyper. But because they're dopamine deficient, they become kind of normal. So there is a sweet spot that we have to look at. And people with ADHD can't be, it's very, very important that you recognize that, because if you treat that, again, you have better outcomes when you treat all of these conditions. Next slide. Now we're going to talk about some evidence-based treatments for substance use disorders. We're going to talk about treatments for alcohol, opiate use disorder, some medications, something that we have been intimately involved with, the development of some devices that has been FDA cleared for some spaces, and then a little bit of talk of some digital therapeutics. Next slide. As far as medications for opiate use disorder, there are 3. Methadone, buprenorphine, naltrexone. Actually, there may be 4. One's called naloxone, but you use naloxone for an overdose. But again, that's another medication used for opiate use disorders. So these are all effective medicines that treat opiate use disorder that are FDA approved and are life savings. These medications could help many people recover from opiate use disorder, but still remain highly underutilized. Actually, fewer than half of private sector treatment programs offer medications for opiate use disorder. And of patients in those programs who might benefit, only a third receive it. So if you can imagine, if you went to a specialist and only half of those specialists would give you medicine for diabetes or cancer, how would you feel? And then there's the patient component where the people still have some feelings about taking a medication or a drug for a drug addiction. And I understand that, but that's why, there were people like ourselves to kind of sift through all these misperceptions, because a lot of people sometimes are misguided that you have to be absolutely sober to have a clean life and survive addiction. But actually, sometimes when in the case of opioids, if your brain has made some changes over time and you successfully detox, that brain is very sensitive to overdose. So we have to tailor treatment for the individual. Sometimes they may need another medication to keep the cravings to go down. There's another medication that blocks the effect of opiates. But it is important that you talk to your patients after detoxification in opiate disorder, that sometimes you are at higher risk after you get detox. So actually, more than 90% of people who went to treatment for detox and opiates will relapse within that year. Next slide. Out of the three types, we're going to talk about one type, the methadone. And methadone is called agonist therapy, which means you're replacing one opioid with another opioid. Methadone is a medication with a long history. It's got actually the longest history of use for opiate use disorder treatment, having been used for the first time in this space in 1947. Methadone is a synthetic opioid agonist that eliminates withdrawal symptoms and relieves drugs cravings by acting on the opiate receptors in the brain, the same receptors that other opioids such as heroin, morphine, and opiate pain medications activate. Although it occupies and activates these opiate receptors, it does so slowly than other opioids. And in the opioid dependent person, treatment doses do not produce a euphoria. It's been used successfully for more than 40 years to treat opiate use disorder and must be dispensed through specialized opiate treatment programs. Now, with that being said, it can keep people away from the illicit drugs on the street. However, because it activates the same receptor, they technically will become dependent on it. So if you skip a dose of methadone, you can experience the same withdrawal effect that you can have with that as heroin or other opioids. Next slide. The next group of medications are called the partial agonist therapy, which means it partially activates the mu receptor. So buprenorphine it's a partial opiate agonist, meaning that it binds to those same opiate receptors, but activates them less strongly than full agonists do. Like methadone, it can reduce cravings and withdrawal symptoms in a person with opiate use disorder without producing euphoria. And patients tend to tolerate this much better. Research has found that buprenorphine is similarly effective as methadone for treating opiate use disorders, as long as it's given at a sufficient dose and for a sufficient duration. Some of the common trade names of buprenorphine are Suboxone, Subzol, Buvanil, Subutex, Propuvine. And there's a new product of buprenorphine that is an injection that lasts a month. So there are new options out there. And again, everything has to be individualized. Next slide. Now, before this year, people who wanted to treat patients with buprenorphine products required a X waiver. It was a special DEA number that allowed you to dispense buprenorphine for opiate use disorder. On January 12th of this year, SAMHSA and the DEA issued guidance on the removal of the X waiver. And many addiction experts for years have advocated in Congress to repeal the X waiver requirement, which was thought to be a significant barrier to the treatment of opiate use disorder and contribute to much of the stigma around the disease. So moving forward, an X waiver is no longer required to treat patients with buprenorphine for opiate use disorder. All prescriptions of buprenorphine will only require a standard DEA registration number. All practitioners who have a current DEA registration that includes Schedule 3 have the authority to prescribe buprenorphine for opiate use disorder in their practice if permitted by the state law. So even though this is a federal thing, there may be individualized state laws that may have differing policies. But this is a federal law that essentially just ripped away this requirement for doctors to have additional training for this. With that being said, there is part of this new law will include further training. So if you apply for a regular DEA license, all doctors will be required to take a similar 8-hour kind of course on addiction. Not only people interested in practicing addiction medicine, but all physicians and nurse practitioners that have writing authority. SAMHSA will no longer be accepting new waiver applications as of this year. So that's a big change in public policy for the opiate crisis. Next slide. The last type of medication that we use in opiate use disorder is the antagonist, which means it's a complete blocker. So what happens is this antagonist, naltrexone or naloxone, sits on top of that mu opiate receptor, blocking the excessive stimulation of dopamine in the brain. So dopamine, again, is the reward chemical, making things rewarding and reinforcing. So if you block that system, there's no reward. So that's how naltrexone works. Now, naltrexone is interesting because it does require complete detoxification. If you add naltrexone before the person is detoxified from opiates, you can throw them into a precipitated withdrawal. And what's interesting about naltrexone is it also has the indication for alcohol dependence. So it's not completely understood why, but the theory is people who struggle with alcoholism have a excessive endorphin release, and this endorphin release fits perfectly into that mu opiate receptor. If naltrexone blocks it, and if the person drinks, there'll be an endorphin release, but it has nowhere to go. It just bounces off that mu opiate receptor, and there's no added reward from that. So it can be very, very helpful, and it actually has an FDA indication for alcohol dependence as well. Next slide. Now, if you've done addiction the last 10 years, there's always been two camps of contention, whether the naltrexone or Vivitrol approach is the best approach for opiate use disorder. And the reason why people may appeal for that is because when you're on Vivitrol or naltrexone, you're not on anything that is has any psychotropic effects. You simply block the opiate receptor. Now, the other side of the coin are medicines like Suboxone, Methadone. They partially stimulate that same receptor. They are the idea is taking them away from the illicit supply of opioids and engaging them in treatment. But the argument is, well, they're trading one for the other. Well, in 2017, there was a NIDA study called the XBOT study, and they showed that Vivitrol, which is the once-a-month injection of naltrexone, and Suboxone were similarly effective in treating opioid use disorder. Because naltrexone requires a full detoxification, initiating treatment among active opiate users was more difficult with the Vivitrol arm. However, once detoxified was completed, the naltrexone formulation had similar effectiveness as the Suboxone arm. Because each medication works differently, the provider should decide again on the optimal medication and consult with that individual patient and consider the patient's unique history and circumstances. So the bottom line is medications do much better, much more superior than no medications at all. Again, the fact that they are at risk for overdose sometimes leads them to quicker, poorer outcomes. Next slide. Okay, this just illustrates the two choices for opiate use disorder. Naltrexone or Vivitrol is a once-a-month extended release form, must be used after detox, and Suboxone is buprenorphine plus naloxone, could be taken orally and used before or even after detox. Both are effective when used as opiate addiction treatment medications. And with that being said, both also have to be supported with good behavioral interventions, good therapy. Next slide. As far as alcohol treatment disorders, there has been actually more treatments in the last couple of years, and other non-FDA medications that have a lot of science and data supporting its use. But the 3 FDA-approved medications include, again, naltrexone, we talked about that before, that has 2 FDA clearances or approvals for opiate use disorder and alcohol use disorder. It comes in 2 forms, a daily pill and a monthly injection. Acamprosate is generic for Camprol, and the way that works, it reduces the glutamate surge that is common when people are just stopping or trying to cut down. There's a chemical that just surges up called glutamate, which sometimes interferes with detox. So acamprosate is a very good choice. And disulfiram is a not so popular medication, but some people will ask for it. Disulfiram is a generic for antabuse, and how that works is if somebody drinks on it, then they're gonna feel sick. So studies have showed that disulfiram actually works in highly motivated professionals such as doctors or pilots that really require complete abstinence. So all 3 work differently, but they're all effective, and all of them should be part of the discussion when you're counseling your patients for alcohol use disorder. Next slide. So again, here are the 3 choices. Acamprosate, and the typical dose is 3 times daily. It's kind of fussy, but you got to take it 3 times daily. And that's the dose for disulfiram. Oral naltrexone is recommended to do 50 milligrams per day, and the the extended release Vivitrol comes in 1 dose every 4 weeks. Next slide. This is part of the talk I really like to talk about. Now, these are the kind of interventions that our clinic at INSynergy like to utilize. It's not something that we it's not proprietary, but we like to take these new innovations in different specialties and implement it in addiction. What we have been doing recently is getting genetic testing in our patients. That's the first thing that we do to see if we can get some insight to whether or not the medicines they're on currently is good or bad. And so this genetic testing is now currently covered by many insurance companies, and actually Medicare and in some states Medicaid, at least here in Missouri, covers different types of genetic testing. And essentially we look at how the body metabolizes drugs or how the body responds to a particular medication. And I've listed a few here, but the typical profile that we use, there's about 24 genes that we look at. I've just listed some important ones here that I think that we look at in most people. So along with how your body metabolizes drugs, there's some signals that give us insight to how that particular person may respond to a medication. So this first one, called OPRM1, which is short for opiate receptor mu-1, can predict somebody's anti-craving effect to naltrexone, and which is very, very important. Like most drugs, there's a bell-shaped curve. Most people will respond to that drug. And on one side, some people will not respond at all. And some people will respond like really, really well to it. This seems to capture this subgroup that responds really, really well. So we like to use that. And in our group, when we first started doing this, we thought that the OPRM1 is going to be all over the place, but we don't see a lot of it. I think about 10 or 15% of our people struggling with addictions come up positive. But when they do come up positive, boy, we have that talk and we're like, God, we got good news and bad news. The bad news is you got this gene that when your opiate receptor gets tickled, you get a kind of get this excessive reward from it. But the good news is when you block it, you have a more robust anti-craving effect to alcohol. So that's kind of a neat discussion we have with some of our patients. Now, the GRIC signal is the same thing as OPRM1, but topiramate. Topiramate is used for seizure disorder, migraine headaches, and weight loss. And we have used topiramate widely off-label in a lot of things in psychiatry, but we have found anecdotally over time, over the years, that it really helps people cut down with alcohol intake. Specifically, we see an effect with carbonated drinks like beer. So the idea is, I think, because topiramate, its mechanism of action is a anhydrase, carbonic anhydrase inhibitor, it makes carbonated beverages taste terrible, and they don't like to continue drinking, at least beer. And perhaps that may be the reason why people lose weight on it, because, you know, a lot of people drink a lot of calories in the form of Coca-Cola or other colas. So that's another signal that we'd like to look at. COMT is interesting because it can identify if there is a deficiency in the dopamine neighborhood. Sometimes, like I said, people with low dopamine have impulsive behaviors leading to ADHD and impulsive drug-seeking behavior. Excuse me. Sometimes when we see a fast-acting COMT, we might have that discussion whether or not dopamine agonists may be good for their symptoms. And their brain may not want to seek exogenous sources of dopamine because we're giving it to them in the form of certain medications. MTHFR is a short acronym for a methylene tetrahydrofolate reductase. And some people with this deficiency cannot properly reduce folic acid, which is a B vitamin, to its usable form of L-methylfolate. A lot of people have depression and anxiety because of MTHFR deficiency. So when we identify this, we introduce L-methylfolate, and sometimes that can help people with their reactivity or their depression. And sometimes we can avoid starting a psychotropic, such as an antidepressant or mood stabilizer, because we've found this deficiency. It's been very, very helpful in treating just people who have emotional dysregulation. SLC6A4 is a signal that can describe if somebody is going to do well on an SSRI. I can tell you most people have a deficiency here, and that's why perhaps a lot of people do not respond to SSRIs. But we've also found out that a common anti-craving medication called Zofran or ondansetron can also be helpful in cravings for alcoholism. And this is the gene that can identify that. And lastly, the DRD2. Historically, this has been considered to be, once upon a time, this was kind of called the addiction gene, but now we know better that addiction, just like other mental conditions, come from heterogeneous sources. It's not just one gene, but the idea was this described a dopamine deficiency syndrome, wherein people are dopamine deficient and they're seeking sources of dopamine, and the brain kind of figures out, hey, I get dopamine from jumping out of airplanes or drinking too much, and it learns over time that this is an easy way to satisfy the dopamine deficiency. So a big theory of addiction is dopamine dysfunction, but it's not the only one. Next slide. Now, I'm particularly excited to talk about these devices that are new out there, and this one called the Bridge is something that we have personally been involved with, the development, implementation of this device to be eventually cleared by the FDA for opiate withdrawal. It's actually the very first intervention that the FDA recognized as a therapeutic, even before medications. And we had this cleared after our publication in 2017. And so the Bridge device is a small electrical kind of cranial stimulator that gives gentle electrical impulses to areas of the ear and the face, designed to tap into cranial nerves. And cranial nerves have lots of functions, but cranial nerves gives us access to the brain and to the spinal cord. And what happens in opiate withdrawal is that there is dysfunction in the communication of the brain and the spinal cord, and that's kind of the reason why people go through withdrawal. In 2017, the Bridge was cleared for symptoms of opiate withdrawal, and many of the people here on this webinar, the staff at INSynergy, along with myself, were instrumental in publishing data that led to the clearing of this device. 1 year later, there was a medication called Lucemira that was also granted approval to be used in the space of opiate withdrawal. So even before a medication was granted by the FDA, it was the Bridge. So patients can use this device up to 5 days during the acute physical withdrawal phase. And we do have this protocol called the INSynergy Bridge protocol that transitions people in withdrawal from opiates to be comfortably transitioned to a naltrexone product, either naltrexone the pill or Vivitrol. And again, giving respect to the brain that's changed over time, that leaving it naked without any intervention actually increases the risk for overdose. So this was something that we developed to get people onto Vivitrol more comfortably. And so again, just to remind people that are treating people with opiate use disorder, people who follow detoxification with complete abstinence are very likely to relapse and return to using of the drug and perhaps overdose. So it's important to, if you use the bridge device or if you use comfort meds, to really drive in that goal that, you know, it's good that you get off of the offending opiate, but moving forward, you got to think about what are you going to do after that, either naltrexone, methadone, or buprenorphine. And there's risks and benefits for all choices. Next slide. This describes some of the, this is what we published in the American Journal of Alcohol and Drug Abuse. And we showed that after the placement of the bridge, the score, the symptom score, after 30 minutes, after 20 minutes, it went down, 30 minutes, and then after an hour, it went down almost 80%. And after 5 days, almost free of opiate withdrawal symptoms. So this led the FDA to actually quickly approve the device, because back in 2017, we were still, unfortunately, in the grips of the opiate crisis. Next slide. Now this slide, if it works, it's kind of an animation. Hillary, can you press, is there a button you can press there that activates it? I guess it's not working.
I don't think so. I think it's not
Yeah.
a video of any kind.
Okay, well, this is the animation. It was kind of neat because you see on the right back of the ear, that's the bridge device, and it's supposed to illustrate, you know, the electrical impulses entering the cranial nerves and then affecting the deep structures of the brain and eventually the spinal cord. So I guess it's not working. It was working with us earlier, but it just kind of showed how that works. So we can go to the next slide. Now, these are other devices or therapeutics, not necessarily for addiction, but it has a promising future in addictions. Now, some people may recognize this. This is a TMS machine, which is short for transcranial magnetic stimulation. Right now, it's got FDA clearances for major depressive disorder, actually treatment-resistant major depression, people who have major depression that had several failed trials of medications. It recently got some new indications for OCD and smoking cessation. So it was the smoking cessation that kind of got me interested. And I know for a fact that currently there's a lot of interesting research with TMS, with cocaine, methamphetamine, and opiate use disorders. They found it very effective for smoking, and they thought, well, maybe other addictive disorders could benefit from this. So stay tuned. All of these three therapeutics have anecdotal evidence for not only depression, ketamine being the new one on the block. Ketamine has just recently been approved as a therapeutic for the same treatment-resistant depression and people who struggle with suicidal thoughts. Ketamine is a different kind of medication. It in the addiction world, it had a reputation for being a drug that was misused on the streets. It is historically used as a tranquilizer that we use in ambulances and in ERs. It can provide a rapid tranquilization. But it also showed some promise in helping people quickly get out of depressive states. Now, psychedelics is the new kind of sexy thing out there, and the verdict is still out. I know that very reputable medical schools, Johns Hopkins is leading the way, studying psychedelics, and I do believe WashU is preparing to study psychedelics for depression. So not yet made for prime time yet, but I know that the research is out there. And we all need to have an open mind to these things, because ketamine and psilocybin have reputations that people don't agree with, and people may even feel that they're risking their own sobriety. But we will wait and see. Next slide. Okay, one last thing, and then we can wrap this up for questioning. We had not only a crisis in addiction, but all mental health during the pandemic. I can tell you, being a psychiatrist, we didn't know what our patients were going to do, because they really, seeing a psychiatrist or a therapist is a different type of medical relationship, right? Being with somebody, talking about intimate experiences, is different than seeing your primary care or your surgeon. And we had difficulty, and we had a little crisis within our field, along with addiction treatment centers. We didn't have our therapeutics was we were told you can't see patients. And that kind of contributed to the increase of depression, suicidal thoughts, and especially in children. The drinking, especially in women, went up 41% during the pandemic, and it was a hot mess. It was a crisis for all psychiatrists and all related mental health care professionals. Telemedicine, digital therapeutics, I think has proven over the last 3 or 4 years to be not only as effective as face-to-face, has actually been proven to be superior in some treatment settings. And one would say, well, how can it be? You're taking away the social aspect. You're taking away the need to come in and do a urine drug screen. What we found is keeping people engaged, despite the fact that they're not doing well, led to better outcome. So we would get people who were not doing well, who are okay to do virtual, and compare that to if somebody wasn't doing well. They're not going to want to come into the office because they're not doing well. They may be intoxicated, they may be on a binge, and they're not there. They don't have the opportunity to have a therapeutic event. But digital therapeutics like telemedicine platforms has really shown that our services could be delivered in an effective, safe way. We saw some of these benefits we saw here. We saw shorter waiting times. I can tell you that my no-show rate at sometimes would be 0 for several days in a row. Compare that to a typical day, I would have at least 30%. I could count on at least 30% of people just no showing. So we saw shorter waiting times, reduced no-show rates, increased privacy, reduced stigma, more care, and because they were in their own environment, they didn't have a lot of guilt and shame. And we have all these digital tools. We got the phone, we got the computer, we got the iPad. There's home monitoring systems for things that other doctors do. I think this is the wave of the future that's not going to go away soon. As a matter of fact, I think this is going to be a big wave, and this is how you're going to be seeing your doctors moving forward. Now, there are sometimes that you got to see a specialist. They got to put your hands on them. You got to do a physical exam, but this is the way it's going to be, folks. And I think we have to embrace it. And we've just seen it being very, very effective. So I know that's a lot of information for an hour. I want to thank everybody for taking time. We got a great crowd today, it looks like. I want to thank everybody for everybody for coming. I know it's kind of a dinner time for many of us, and it's probably sleeping time with our friend in England and Europe. So at this point, I'd like to end our little talk. don't know if there's any questions that you wanted to pick out, Ashley, and perhaps I can answer them if you want to read some of the selected ones.
Dr. Addy was actually asking about Librium and its role in treating addiction.
Okay, good question. So Librium is a long-acting benzodiazepine, typically used in alcohol withdrawal. Okay, and it's important that you identify and treat alcohol withdrawal, because if you don't treat it, it can be severe enough to produce a seizure. And 10% of seizures, you can die. So it is a dangerous, a very life-threatening condition. So Librium is a good choice because it's long-acting. Some of the not so good things about Librium is it's long-acting. So people who are a little bit older, who tend to metabolize these medications at a slower rate, like anybody over 50, I would not use Librium because it can cause delirium, because they're not breaking it down, and they could, if you're giving it as an outpatient medication, they can slip and fall and crack their head. But in that case, I would use a shorter acting medication like lorazepam. Thanks for that question.
Ms. Perez has a question about co-occurring mental health conditions, and she's wondering, do these conditions cause addiction, or does addiction cause them?
That's a great question. Dr. Perez, thank you for coming. Nice to see you. So the question is, co-occurring mental conditions, do these cause addiction or vice versa? Well, both. But what we see is a predominance of people coming in for addiction have a co-occurring condition. I have the fellows from St. Louis University, the addiction program, the addiction medicine fellowship, and they come to our clinic because our clinic is one of the training grounds for them. And so the first thing I tell them is, if you think you're going to learn addiction, you're mistaken. This is just a fancy bipolar and ADHD depression clinic. If you don't identify those conditions that show up over and over and over again, the medicines like Vivitrol or Suboxone or Antabuse, you're not going to have a good outcome, because oftentimes those co-occurring medications are fueling the addictive behaviors. Now that's not absolute. There's certain things that we're seeing in genetics, that there's some people who kind of get a exaggerated effect from just alcohol, and they like it, and they may not have any comorbid conditions. But in general, you have to really look and screen for these comorbidities. Great question. Okay, there's a question here. Where will there be a video recording to review later? We are working on that. We've got, people smarter than me that's going to make that happen, but certainly we're going to be chopping some of this up and making it available on all our social media outlets. But yes, that's in the works right now.
And also we will have it on the website, INSynergySTL.com. There's a provider page now, which we will be adding information, and we will have the video recording, well, hopefully as much as we did get might be on the website. And the one other thing I wanted to ask of you, if there aren't any more questions, or please feel free to throw out some more questions, is if any of you have any topics that you would like to see for future events with Dr. Taca, please throw them into the chat. We'd love to know, if there's anything, you would like more specifics, more details, more in-depth of some of the overview that he gave today. We'd love to hear from you on that.
If there's no other questions, I applaud everybody who came in, including you, Hillary, for setting this up, and the staff of INSynergy. this has been a great experience for me, and hopefully we'll get to do this on a regular basis and continue informing everybody who is in this space. Dr. Valena, thank you. I see you there. Thank you for coming.
Very good. Thanks so much, everybody, and have a wonderful evening.
Okay. Tony, how you doing, buddy? I need to call you later on a personal note. Tony Valena is a classmate of mine. I will call you afterwards.
Awesome presentation. Thanks. I'll talk to you later.
Yeah, hello to the family, Tony.
Thanks. Bye.
Bye. All right, I'm going to stop the recording.